So, hello everyone. We have a few people already in the breakout. We have some others that have been assigned to the breakout or have requested to be in the breakout. My name is Silvana Mazzella. I'm the Associate Executive Director of Prevention Point Philadelphia. Co-facilitating this breakout is David McKeegan. Can you introduce yourself?
Thank you, Silvana. I'm David McKeegan. I'm one of the original members, as well as Silvana, in the ROPC, and I work for the Chester County Medical Society.
We additionally have Zoe Zoslow from the Super Program at PDPH doing tech for today's breakout session. Hello, Zoe. That was a fabulous, fabulous panel presentation earlier. Panel announcement on Philadelphia. And then we have Mallory Trainer and Taylor Soball doing note-taking for this breakout session. So we can get started. I again think that it's worth noting that the panel was awesome. We intentionally had the highest level of leadership for our state around drug and alcohol programs, recovery, and harm reduction. We also had one of the leading policy scientists from around the country and Drug Policy Alliance talking about harm reduction policy at a federal level. We have one of the largest philanthropic organizations that is supporting harm reduction in the country, and sadly there are very few, talk about harm reduction policy at the local, state, and federal level. And we had one of the leaders in law enforcement for our region and around the country speak about law enforcement harm reduction collaborations and some of the controversial but groundbreaking collaboration happening to advance harm reduction. So I wanted to just start by picking up a little bit on some of what Secretary Smith talked about earlier with, the state of work in Pennsylvania around reducing overdose and substance use, and the idea that recovery and harm reduction are two critical coexisting linchpins to reducing overdose and advancing the health of people, particularly people who have or do use drugs, and that they're underfunded. Also piggybacking on the comment that harm reduction can be funded creatively, and looking at collaboration and public-private partnerships as we follow up on this idea of the spectrum of harm reduction, debunking myths, looking at opportunities and efforts, how we make our business case in your counties or programs for harm reduction, and how we pay for harm reduction. So again, if you have any questions or comments, please raise your hand and we will ask you to unmute. Okay, I don't see any questions right this second. So I might then ask some of the participants in this breakout if anyone would like to share any of the efforts you have underway in your county or programs related to harm reduction, and what type of supports you're seeing or what types of barriers you might be seeing right now in advancing harm reduction.
I don't personally work in harm reduction, but I live in the Southeast region, and I regularly see protests in Philadelphia about safe use locations. Can we talk a little bit about that and how you address that?
Yeah, thank you for asking about that. I think we would be remiss, as Jeremiah Daly brought up in the panel discussion, we'd be remiss in talking about harm reduction if we did not also talk about some of the controversy. And I think, the stage was set earlier today with the acknowledgement that harm reduction is public health. They are sound public health interventions. And if we make our North Star, preventing overdose first, that guides everything else that we do. That being said, there is a lot of controversy. Immediately pre-pandemic, there were efforts in Philadelphia to advocate for, support, and create safe spaces for use from a public health framework, including offering induction to MAT on site, et cetera. And there was a lot of community discord over this. And I think, something that Secretary Smith said earlier really hit home, this concept of substance use as potentially being fluid during a lifetime. We know that people will embark on recovery if they do. And for some people, that may be lifetime recovery with or without additional supports like substance use treatment with MOUD or meetings or fellowship support. And for other people, recovery may be temporary. People may lapse, people may fully relapse, people may go back into treatment. And so, keeping the understanding that this is just one intervention or one opportunity to keep people alive is important, but that for many people, especially in Philadelphia, we are a treatment community, very, very treatment-oriented city. It is hard for people to understand that harm reduction and relapse use may coexist along a continuum for some people in the stages of change. And we had someone that wanted to leave a hand.
Yeah, hi. I just wanted to, this is off topic of what we were just talking about, but I just wanted to talk a little bit about my program because it's new. And I think this is directly correlated to kind of our discussion. So I work for Marikey, and I work under the addiction services, and we started a community treatment team program specifically for adults struggling with ongoing drug and alcohol concerns. And the idea is to help these individuals to reconnect with their family of choice. So I think, just to make mention, I think it's important to note that they are not required to be sober to be in our program. We support them either way. If they need a higher level of care, we also would make that recommendation. We take individuals who are MAT and non-MAT, so they could, again, be anywhere on the spectrum. And we work to wrap them in services. And I think in a way, and we also have Narcan like on us. So I think that my team is kind of ready to in the trenches, ready to do harm reduction on a daily basis and be at our clients' beck and call wherever they are at in the recovery process. So I guess I just wanted to share that a little bit because I think that it's a new program, and Marikey is trying their best to not just offer outpatient services, but also we're able to go to them in the community, and maybe we can outreach more individuals that way.
And Hannah, what county or what area is your agency in?
Philadelphia County. It's the county's Philadelphia, so we serve everybody within the Philadelphia city limits.
And thank you. Marikey has been a great partner to Prevention Point, many other providers, and in the PAD program. But I think that highlights too, to your question about controversy, that part of what we can do in all of our disciplines is advance the idea that harm reduction and that the stages of change are along a continuum, and that we need to create opportunities for everyone to stay alive at any stage that they're at. And that includes multiple interventions to address that.
And if I don't mind, if I could jump in, one of the things that we did not get to in the plenary session was a question regarding discussing harm reduction in the context of conservative communities. We know it came up in the discussion, people are all over the map in terms of the sort of belief or acceptance in harm reduction. You know, Jen Smith directly addressed the idea that you could be enabling drug use, which is not the case. You know, Jerry mentioned the law enforcement community is really sort of hesitant about certain actions and okay with others. And so there's a vast continuum of where people are with respect to harm reduction. I wondered if anyone could address or talk about anything that they have found successful in sort of persuading people who maybe are more conservative, or things that are more palatable to more conservative communities in terms of sort of initiating or sort of selling these services, encouraging these kinds of things to go through.
Renee, it's Vince. Can you hear me?
Yes, we can hear you.
Okay, I can't raise my hand that I don't have video, so I wasn't sure.
We can hear you.
Yeah, thanks. If it's all right, I'll just take a stab at that or share some thoughts. We've been having discussions in our county for quite a while as far as harm reduction and what it looks like and how, you know, what it should be and that type of thing. In the discussions here, I mean, a couple of things that I communicate or we think about is that, number one, harm reduction is a full range of different services. I think where you run into the controversy most often is when you're talking about safe injection sites and syringe exchange. And I don't even know so much that the test strips are as much of a controversy, at least, you know, as I'm having the conversations here in Chester County. So I think the one thing that may be helpful, and it's what I've tried to do internally with my staff and with our systems and stuff, is to explain that harm reduction includes like Narcan, medication assisted treatment, and things other than just needle exchange and safe injection sites. I think historically, at least from my perspective, I've been in the system too long. When we talked about harm reduction years ago, I mean, the only thing that really was being discussed was needle exchange. It wasn't even safe injection site at that point. I think, at least for some of us older ones, I'm not sure if that's the only thing, but so I think there's some of it is probably defining what harm reduction is, and the fact that we're doing harm reduction services in a lot of what we do in the county, and I'm sure in the other counties as I talk to them. So I think maybe an explanation on what it is, and yes, there, you know, I think in some places the syringe exchange and the safe injection sites are going to probably continue to be controversial, and I think it probably needs to be, I wouldn't even say county specific, but what's discussed and what the needs are can be very different, or at least envisioned as being very different. So I think it's starting with the conversation of what is, when you say harm reduction, you know, what are we talking about? And then, you know, kind of self-educating and educating others, and then moving from there toward what's the appropriate thing for the region, for the community, for the payers. You know, if you're trying to convince commissioners and that kind of thing, it really is an explanation, and then, you know, going from there, if that makes sense.
I totally agree. And you know, anyone chime in. I mean, I think that when we think about harm reduction, obviously we do syringe services, but we have 17 other programs. And the idea is that any service that seeks to engage people who use drugs or have used drugs, that specifically provides services to them, particularly related to their substance use. So that can include health services related to wounds or previous conditions. It can include infection prevention and other prevention services. It can include housing and other durable survival resources. But anytime you provide services to people to reduce prior or current use harm of substance use, that can be a harm reduction service. And part of what the Regional Overdose Prevention Coalition has been doing in the last few months with support from Vital Strategies is specifically providing training or support around that spectrum of harm reduction. So yes, you know, there might be counties or agencies or people that want to do a syringe service program, but it can also include naloxone distribution, and most specifically targeted naloxone distribution, where we are specifically trying to not just get naloxone out to everyone, but we're trying to give the majority of that out to people who are actively using substances that put them at risk for overdose, and not just opioids, but as was discussed earlier, stimulants, including cocaine and methamphetamine in the various forms, people that are buying pressed pills that might have fentanyl in them, people that are using prescription substances and or misusing prescription substances, and otherwise at risk for overdose. So there are multiple ways that we can reach people and multiple services that we can provide people, including wound care, hepatitis C treatment, HIV treatment, specific low barrier healthcare services, housing and entry to the homeless services system for some, case management and safe places to talk to people. So there's a whole range of harm reduction services that are less controversial, let's say. But I think what is unique about harm reduction services is that they're specifically engaging people who use drugs or have recently used drugs. And you know, one of the things that Secretary Smith talked about earlier today was the Next Distro program and the mail order naloxone. Part of why that's critical is because we know that, you know, for example, when substances are used in areas with a large unsheltered population, it's actually easy to find people and do outreach and distribute naloxone. It's much harder to find people that are at risk privately in their homes. And it's much harder to find people that will come to harm reduction services unless they are very visible. So I think, you know, one of the controversial things about harm reduction is creating spaces for people to come and get services. And one of the advantages of syringe service, even though it is very controversial, is that there are durable physical places that people can go to get multiple types of service. So without doing syringe service program, I think some of that, you know, we have to be creative about creating enough, you know, buy-in and highlighting the other ways that people can access harm reduction services that are not that.
And Silvana, I'd like to follow up and just say that, in my opinion, in the short time we've been working together as an ROPC, there have been 3 or 4, or 2 or 3 at least, other really significant developments. I think we see a much greater acceptance of MATs throughout our whole region,
Yes.
including within some of the more critical components, such as law enforcement. And I think that's terrific. We are even now getting to the point where we're going to begin in many places with MATs in prison. I think that's terrific. The warm handoff. That was, I think, one of our very first things that we really all did well. And the development of certified peer recovery specialists to enable that was really terrific. And it all goes to me still in terms of teeing this up as a disease rather than a moral problem that someone has. I wanted, though, to ask a question and see what you thought, Silvana and others. In some of the research that I've been doing about harm reduction, one of the things that comes up often is to include people who use drugs in the planning and in the implementation. And I guess I wonder, A, how successful you are at doing that at Prevention Point, and B, what would you recommend to those of us in the outlying counties?
I think that's a great question. And it is something that we do in multiple ways. So a first way that we involve people in the planning of services is through a participant advisory board. We have at times had a more active one than at others, and sometimes these are by program or by service. The other way is through employing people with lived experience, and all harm reduction programs do that, as do many of your programs. And that can be, you know, people with fairly recent lived experience, or people with prior lived experience that are now in recovery. Another way is by consistently doing needs assessment and asking people what services they need. And so to the earlier point about, for example, the controversy around syringe service programs, we know that even our own participants sometimes will not go to the syringe service program in the building or in the area that they live in because they don't wish to be seen by other people, or they will come to the in-building program where they can also access other services. So it's critical to not just create a harm reduction service of any kind without, there has to be real needs assessment and involving people. The other way is asking people what specific services they want, what do they need, so that we are constantly asking people what would be helpful for you in terms of your health, in terms of your personal needs. And that guides all of the programming developed. So, you know, an example is that we did do primary care a few years ago. And there wasn't that much buy-in among participants, but people said, you know, if you provide hepatitis C care or HIV care or wound care, that is what is needed. And so those are the services that we focus on. And I think for all of you that are working with individuals in direct service, it's doing what you already do in your programs, asking people what they need and asking people how to deliver it and who should be delivering it, what type of staff are needed to deliver services. And people that are in the group, what are your experiences, to David McKeegan's point about specifically, what have been your experiences in trying to develop harm reduction initiatives or directly involve people with lived experience in the work that you do?
Hi, I can, if that's okay, I'm Jen King, I'm the executive of the Council of Southeast PA and PROACT. And one of the challenges we face is that we serve four, we work with 4 single county authorities, and Philadelphia, Chester, Bucks, Monco, all embrace this, but to different degrees and different levels. So we want our organization to kind of be aligned with everybody, and it can be challenging to know exactly where to position and what to champion wholeheartedly and forward thinking, and where we learn and grow, and kind of let others lead. It can be challenging.
And this kind of relates to one of the, I guess, talking points in our introduction of the breakout, making your business case for harm reduction. One of the things that we know, and this also relates to what Vince asked earlier, is that we have different needs for different populations, for different areas. I liked what Sheila Vicaria said earlier too. We can't just focus on one type of harm reduction initiative without really looking at the data and looking what we have. So for example, in preparation for a previous event with Regional Overdose Prevention Coalition, we looked at some of the data for the 5 counties that we have included in our OPC. And we know that each of our 5 counties has roughly 3 to 5 zip codes where the majority of overdose fatalities happen and where non-fatal overdose happens. And that when we look at maps, those are clustered in particular areas. So for example, you know, I love the work that some of you are doing around hotels and motels, looking at where fatal and non-fatal overdoses have happened, looking at beyond the zip code level to a much smaller geography, and then looking at what types of entities are in that geography and being able to pinpoint that certain things are happening either in certain types of facilities, certain intersections, et cetera, certain populations, and then can we focus our work there? And so that's an example of not just looking at syringe service, but looking more broadly at other types of harm reduction and including looking at data, but also talking to people and finding out where the need is and what kind of interventions would be most useful.
I see Marie has her hand
Yeah.
up. Let's ask Marie for her comment.
Hi. Yeah, hi, I'm Marie Datillo. I'm a family member who's been impacted by substance use disorder and actually a recently joined the ROPC board. And so I haven't really done work in organizations similar to what most of you have, but from a family standpoint, I do what I can with prevention and education and trying to help people to understand. And I just wanted to share a quote. I do a lot on my social media page to try and help people understand. And I've had a really difficult time, even with my own family members, in helping them understand harm reduction. It's been very, very frustrating for me. And several months ago, I did a lot more research on it. And I came up with this quote that I think speaks to what Jen Smith said this morning and what we're saying here. And I just wanted to share it because it so very much resonated with me. It's a statement that was written by somebody named Stanton Peele, who's apparently a psychologist in the field of addiction. But what he says about harm reduction, he says, harm reduction is helping people non-judgmentally to live their best lives, starting with surviving, no matter where they start or what hole they're currently in. Meanwhile, the helper wants to convey his or her confidence without criticism that this hole is not their permanent resting place. And that just resonated with me so much. I mean, it doesn't talk about the specific programs, but it says what we're trying to do. We want to keep them alive. We want to do whatever it takes to keep them in survival mode and until we can hopefully get them to a place of recovery. I lost my grandson to a heroin overdose. It'll be 7 years ago on Monday. And that's where my passion comes from in this. And hopefully I can contribute and do something going forward. But that quote really spoke to me. And since it relates to what we're talking about here, I just wanted to share that. Thank you.
Thanks, Marie. How about Hannah Jenkins again?
Yeah, I just wanted to, I guess, piggyback. I mean, I agree with what you guys are saying and to answer Dave's question. So I do think that, at least for my program, for addiction specifically, I've worked in mental health and I've shifted to addiction, is that our CRSs, our certified peer supports, are, because they've had that experience, are like very, very crucial to our team. And not just because my staff members can learn from them, but that helps us to be able to get the clients involved, more involved, their buy-in, and then of course the families that we're reintegrating into, to get that family to understand that there is such a big pendulum of where this person could be in recovery at any given time, and hopefully helping to, like Marie was saying, understanding that process as a family and help, and how they can help that individual. And it might, like we were talking about, it could seem as enabling. I think that that's the biggest stigma in an odd way, but I think that it's more so, like we said about the education, knowing that there are so many different ways to get resources. And I mean, I think if I ever had a staff member ever not really understand what harm reduction meant, I also can always relate it back to, I think it's the stigma, because I know when I worked in mental health, we were constantly taught as counselors, you meet the client where they are. And I think that is not really taught for drug and alcohol recovery. It's like, well, everybody just needs to be sober. And that's not meeting the client where they are. that's not at all the modality that, you know, we should be striving for. And I think that's, I think that that's probably just the stigmatizing it, and the fact, I know that it's illegal, but I think it's sad to think that, you know, we would never discredit someone with a severe mental illness and, you know, think that a different level of service would not be appropriate with them. I think that we would definitely go to all lengths to try to help that individual go to whatever type of service they needed to. And I think we should do the same for people who need recovery, who have substance use disorders, because they are all disorders. They're a lot the same.
Thank you, Hannah. How about Colette? Colette Green had a question.
Hi. I'd like to agree with you know, all those different definitions of harm reduction and kind of how to engage people with substance use. And the clients that we serve come in, substance use is just one component of who they are and what their needs are. And so we have a program geared specifically to pregnant women and women with young children, ages 0 to 3. And often, you know, we will use whatever door they want to come in and receive services. And usually it's not necessarily first substance use issues, but what they need, you know, to prepare for their baby, what kind of services, what kind of, you know, we help people with finding employment, with connecting them to clothing resources, and then working with them very intensely. And one of the other things is really kind of meeting them where they at, also literally. And I think that sometimes in some programs, one of the barriers is that the client needs to go somewhere in order to be connected. And we really try to focus on going to them wherever they might be. And really is very much at first a hand-holding type of program where we do intensive everyday conversations every day. How did that go yesterday? What do you need today? And really understanding that the beginning of treatment is intensive, and it can be long, it can take however long it needs before they're connected to more long-term stable services. And so our program was funded by Vital Strategies, really, again, to address those specific needs of pregnant women, because the stigma and the barriers to treatment are even so much higher when we're talking about this population. And oftentimes what keeps them from accessing services is the fear that their children will be taken away from them. That keeps them from getting their medical care is need. So it's really about trying to connect with whatever it is that they most need and want at the time. And it doesn't have to, you know, refer specifically to their substances.
Colette, where is your agency located?
So this program is running in Philadelphia right now, but we're maybe looking to expand to the other counties, you know, and partnering with other counties.
Well, and you mentioned child and maternal health. That's come up ongoing through our ROPC with many different groups in each of the different counties. And it's a real delight when you see how often that's embraced.
Mm-hmm.
I'd like to ask, if I could, to recall Marie for a question I had. Marie, I'm afraid maybe you understated some of your involvement in the community. I'd like to ask you to tell people about GRASP a little bit. I'm hoping that there'll be more GRASP groups that can form in our area.
Sure, David. Well, as I said, I lost my grandson 7 years ago, and there literally were no grief support groups. There's no place for someone to go when you've experienced the loss of someone through a substance related type of a death. There's Compassion Friends. There are many groups that are general, but nothing specific to overdose. In my search for help, I came across a national nonprofit, GRASP. It's Grief Recovery After a Substance Passing. It's all peer run. We're not licensed psychologists, but I was in a coalition that David was part of, Delco Survivors United. And we were trying to look at how do we address people who are grieving in our area. And myself and Margie Craig, a mom who lost her daughter, decided we would start a GRASP group in Delaware County. So we've been meeting for about 2 years now. And we vet people by phone. It's just open to someone who's lost an individual that they cared about through a substance use type of a death. We meet once a month on the first Wednesday of each month. We met via Zoom during COVID. And I have to say that similar to what we heard in this morning's session, the numbers are going up. We've had more and more people call for assistance. And and fentanyl. Last month, we had 3 moms attend the meeting. All 3 lost a child to an overdose with 1 pill. They bought drugs on the street. They were counterfeit pills. 2 thought they were buying Percocet, 1 Xanax, and the 1 pill killed each one of those kids, all like in their 20s. I just met with a mom the other night, an aunt, her niece, and also what we spoke about earlier with co-occurring issues. She has mental health issues, had been to the crisis center many times, had overdosed several times. Her dad just picked her up in Kensington not long ago. And last week she injected heroin and committed suicide by train. She stepped in front of a train. When we're trying to work with that mom, it's just, the cases are just that they're not stopping. We're doing what we can to help, but we're one grief group in the area. We do direct to other types of grief groups, but I wish there were more grass groups in the area. We would just need more people to, step up to chair them. It's not easy because again, I'm not a therapist, and you get these sad phone calls and you're working with people to try and help them through the worst experience of their life. And the group dynamic does help when we have people with us in the room. And Margie and I try to send emails and text in between when we know that people are, very much hurting, and the once a month isn't really enough. I know in Philadelphia, I don't want to take up more time, but I believe her name was Patty Vargas. The medical examiner's office in Philadelphia has a licensed therapist that when someone dies from an overdose in Philadelphia, that this therapist reaches out. She works with them free of charge with the family members. And I believe she told me she does 6 sessions, and then she refers them out. So she's been referring, if they're in Delaware County, she's been referring the families to our grass group. And I wish more counties could do something like that, where we would actually have a licensed therapist on board to get through like those first initial weeks and months. It's critical. So hopefully we can do things to expand in that area as well.
Yeah, thanks for bringing that up, Marie. We actually have just expanded to have 3 licensed social workers that provide these services. So I'd love to share something in the chat about it. I was just nervous because I'm recording and I didn't want to go off of the screen and everything, but I will put that in there. So thank you for plugging it. And I'm glad that you're getting referrals from them.
Yeah.
And I know New York has a model program out of the health department where they have been also visiting survivors in a family where there has been an overdose, or a peer or partner where there is co-occurring substance use. Those individuals are also at extremely high risk for overdose. So part of that model is going out with the health department and visiting people and offering training, naloxone, but also other social services to any of the peers, partners, or family members that might also have substance use in their background. Also, thank you so much for what you do, and for being such a caring advocate and providing that support and doing it as a volunteer. I mean, so much of what we do around recovery and harm reduction starts out that way. Sometimes it stays that way. And so I would like, before we finish, to just talk about the creative ways to pay for harm reduction. But the recovery specialist role was brought up. And I think, to the earlier discussion around what other types of harm reduction in that spectrum, here's another great opportunity where we don't have resources for a harm reduction specialist, or maybe enough work for one person in that team. This is an opportunity also to cross-train certified recovery specialists, many of whom are really, avidly interested in providing additional support. There are, all of us do work with people who have recently overdosed, and sometimes that is not the time that they're interested in treatment. or we might work with people who are in a different stage of change at that moment. And so for those individuals that don't say yes, this is an opportunity to cross-train harm reduction, to cross-train the certified recovery specialist to also talk about ways to engage with services, how to keep that door open, and to provide some harm reduction counseling in that moment. So that's also an opportunity that we can use. And I think that, you know, the Meraki example, we've certainly seen that in Philadelphia, where the outreach and engagement is multi-focused depending on where someone is when they're being outreached to.
So Silvana, this is Marie again. If I could piggyback just a little bit on that, I recently completed training to become a certified family recovery specialist. I completed that training in December. And I think that's another area where we can expand. I mean, expand the role of the recovery specialist, but also involve the families. Back to my example, my grandson overdosed the first time on April 28th, back in 2014. And we went to the hospital and he was treated with Narcan and we left, and no one ever spoke with us or gave us any information, any education, whatnot. 2 months later to the day is when he overdosed the second time and died because there was no one there. Hang on. But I think we have an opportunity today with the family recovery specialist. It's a fairly new role, but in addition to having the certified recovery specialist for the person with the disorder, have the family specialists also involve the families and help to educate them and bring them into the fold and help them. I think from a harm reduction perspective, that would also go a long way. So I think there's room to expand the recovery specialist program to include family members as well.
As a family member, I agree 100%. And as a newly certified family recovery specialist as well.
And some of what we've seen with a few programs and some health entities is that they have come to this kind of compromise of, we will discuss harm reduction with someone at risk for overdose after we have offered substance use treatment. And we've offered substance use treatment more than once. They've still declined at this moment. So now we're going to have that harm reduction counseling discussion. In that, you know, in keeping with that idea of this, like our North Star is meet people where they are right now and offer them a range of services to keep them here and keep them engaged. Data came up earlier, and I was wondering if there are, if any of you would like to talk about either a challenge that you're having in considering or adding or expanding harm reduction to your services, or if there's any way that anyone else in this group can help people make that business case for harm reduction. I mean, I guess I'll just say that I think there are, you know, if we, for example, Zoe was talking earlier about some of the fatality review and some of the data. One of the things that looking at data for our counties or programs can tell us is what kinds of issues we have and where, and what kinds of, you know, where to target services and maybe what to offer in those services. So for example, the education that is both general but kind of specific to different types of substances, so that we are not just doing outreach about one thing, but we're targeting different messages in different places. So for example, we might have media messages or palm cards around fentanyl and certain substances in one area, but then fentanyl and other substances in another area, and similarly involving our healthcare providers. We know that just in Philadelphia, depending on the part of the city we might have a spate of fatal and non-fatal overdoses at one hospital that are co-involving certain substances, but in another part of town, there are overdoses involving other substances. So directly involving and doing education with healthcare providers and others that is specific to the needs. So maybe in the absence of other immediate questions or chats, could some of the people that have not spoken, would you mind introducing yourself and what you do and what your interests in harm reduction are?
Let's ask Kristen. She has her hand up.
Hi, everybody. I'm going to leave my camera off because I'm multitasking. But I work with Health Federation of Philadelphia. And for the last about a year, I have been involved in educational programs for perinatal providers of all sorts, whether that's, healthcare providers and nurses to social workers. And I just wanted to say that I think, Renee asked about how to approach more conservative groups. And of course, you can't really generalize, but in some ways, I would say that perinatal healthcare providers can tend to have a conservative way about them when it comes to harm reduction, just because it kind of goes against the grain of their training, perhaps. But in introducing providers to certified recovery specialists, and having them hear about ways that you can actually help a woman who may not be ready for treatment yet, that there's value in harm reduction, that it's not, a failure on their part, if they're unable to quote unquote convince a woman to move into treatment if she's not ready yet. But I just wanted to mention that I think that has been really crucial to working with perinatal providers in the Philadelphia area. And we have educational trainings, and we also have a monthly learning collaborative for perinatal providers. And another important piece there is that we have connected doulas who work specifically with pregnant and postpartum women with substance use disorder. We've linked them with the providers, and they really have their ear to the ground on what's happening with women and can give specific examples of, where there may be breaks in the system that can be addressed that, others just wouldn't know about. They don't work that closely with women. So I just wanted to mention those things, and I will mute.
And thank you for bringing that up, because that is, one of our biggest areas in harm reduction that we really need to focus on as a system is destigmatizing perinatal substance use. We want to get women coming into our programs, because if they are so shamed about asking for help, they're delivering on their own. They're delivering under less than optimal circumstances, and so are their babies. So this is just a great example of why it's so important to destigmatize and to open up all of our doors for people to come in and get help at any stage. Vince, I see your hand raised.
Yeah, I just wanted to go back real quick, kind of look at a kind of a different angle, maybe on the data. Like a lot of things, and when we look at the opiate epidemic, I mean, one of the things that's always out there is, we had 100 and some people die in Chester County from an opiate overdose or drug overdose, with most of them being opioids. At the same time, and I tried to quickly insert it in my little summary this morning, we had 440 people that had a reversal just by our EMS and our police. I don't know how many other ones by the public or other ones. I mean, that could have easily been 500 plus people in 2020 that had died. It's kind of same type of thing when we do, and kind of say it. Sometimes we need to flip the numbers over, and I think that might help sometimes with showing people that may not be into the quote unquote harm reduction and the different things that they do work. There's positives to it. You know, I run with an ambulance company here, and you know, the same type of attitudes you hear in a lot of places. You know, the drug addict, I've been there 14 times, and which is always, you know, that's an exaggeration, number one. But you know, if we can actually show, you know, we have warm handoff in our ERs. If they can get that person to the emergency room, there's a good chance we can show from our data that, you know, 8 out of 10, 7 out of 10, whatever the number is also going to make it to treatment. So I think there's a lot of things that we're doing that are very positive. And sometimes we need to educate those that may not be as aware of it, that what they're doing is making a difference. They don't see the end result of that. You know, they pick up, and they do. You know, we've been to the same place at different times for an overdose, and you know, you do the Narcan and stuff, and the last they see is the person being, you know, dropped off at the emergency room. So, and that's just one example. I think there's ways of looking at data, some different ways in using that. Just kind of getting back to your question before. You know, we do. There's looking at, you know, the financial piece and all that, and depending on your target population or who you're trying to convince, you know, dollars would be good for the politicians and the legislators and that kind of thing. But at your local level, when you're trying to show that something works, I think that's really a helpful type of thing. That's just a thought, you know. We've tried to do the same type of thing. A lot of you guys are probably familiar with the PAYS survey. You know, the PAYS survey comes out, and you know, it looks like every kid in the school must be using drugs or something. But when you really look at the numbers, it's like, it is. It's a lot of number. I mean, it's a high number when 15% of 12th graders are using a certain substance. When you flip it around though, and 85% haven't used, period, you know, it kind of balances the picture, actually makes it a little more favorable. So anyway, just sometimes looking at the data, kind of spinning it a different way can be helpful.
And this has been one of our focuses from the word go with the ROPC, was to share data. And lots of times when you're sharing data, like on Narcan reversals, it helps to convince other communities that aren't yet on board that it really does work, and it's a cost-effective way to do things. So better understanding and sharing data, I think, is a huge part of our harm reduction strategies too.
And sharing experiences and messages. To pick up on the recovery specialist angle, years ago we had the deputy police commissioner come through our building to look at some of our programs and look at the syringe service program. And you know, one of our staff at the time, you know, walked up to him and talked about how he had been reversed by an officer, and that it had been life-changing, and that part of why he was working in a harm reduction program was to be a bridge for other people that weren't yet there. So I think that angle. And then I know Melissa wants to say something. I just want to also add that I think in courting our, making our case and advocating for harm reduction, in addition to finding your support and your good arguments, you need to know who is opposed. And you need to find what argument appeals to them. What makes this person tick? What makes this group of people tick? What do they care about? They may not care about overdose. They may care about public nuisance on the street. They may care about homelessness. They may care about some other aspect of these issues that we're grappling with. And maybe that can be the hook. For some of them, it's healthcare dollars, right? Sadly, we talk to people sometimes that the people themselves may not be the most critical thing, but how can they keep people out of the ER? How can they keep people out of this service? How can they change that dynamic? So part of what we are looking at, especially all of you that are working in public health or substance use treatment, is what argument is going to appeal to someone to address that opposition to what we're trying to do. Melissa, did you want to say something before?
Jen, and I logged in as Melissa.
Yes.
I don't know. I had trouble this morning and needed help at the last minute to get my login. So, and then I, of course, don't know how to change it. But I just want anecdotally, one of the things that we've been doing warm handoffs for several years, and I have the privilege of then talking with hospital leadership in the emergency departments, and the power of the growing workforce of CRS and their personal testimony, and then working side by side is such a powerful stigma reducer. I'll hear nursing managers say, I could do stigma reduction training over and over again, but having the CRS work in my where you know, and I'll just use a name, but having Becky in as part of our team, and then learning her story and learning that she survived overdose 3 times, and hearing how she talks to an overdose survivor in the moment. Just so the more that we can spotlight the power of this workforce and their own stories and what they bring to the table, can go so far, because, you know, I've seen a difference in my time, and heard testimonials from hospital staff that's taken their work as a workforce change manager, taking it leaps and bounds, because it's you know, it's not forced upon the hospital staff. It really, it's a mutual respect with a teammate. So the more that we can as an industry celebrate that and highlight that, probably the better.
Thank you for bringing that up. That's definitely been the experience at HUP, Einstein, and a lot of other large institutions that have grown their recovery specialist workforce. And making the issue humanized for many people, and showing the value that you can make change with each and every person. It's going to look different. Some people say yes the first time, some people don't, but we can touch people, and we all have a role in touching people as a critical touch point where we can make a difference in someone's life. I think one of the things that I think about that's related in our work, just because we have so many, I mean, 15,000 people in a year, is this might be the only time you talk to someone. It might be the only time that they stop to hear what you have to say or to share their story. So when they do, we're going to listen to their story, and we're going to offer, sometimes in sound bites, but we're going to offer a pearl of wisdom, overdose prevention, what we've got to offer, because this could be the chance to make a difference.
Let me throw out one other really significant advance, and it takes us all the way back to the 2 meetings we had before the ROP was founded. It was on safe prescribing, or responsible prescribing. It was concurrent with the development and implementation of the PDMP in Pennsylvania. But I think that we could probably say safely that one of the biggest changes that has occurred has been that fewer physicians and other providers are writing inappropriately for opioids. I'd kind of like to hear some comments from people, though, to see if that passes water. I know a lot of people have done really, really great work in putting together programs for physicians and other prescribers. I think it's had a big impact, but I'd like to hear what you guys think too.
So I can share a personal anecdote. I had a fall in January, and you know, was sore for a couple of days with probably a bruised rib, but day 3, it hurt when I breathed, when I took a breath. So I went to my family physician, and I just wanted them to listen to my lungs and make sure I didn't, you know, tear something or puncture something. And that wasn't. But at the end of the appointment, she offered me opioids. And I said, I told you I came here from work. Like, I'm clearly functioning in my day. Can I tell you a little bit about my job? And we fostered this conversation, and she really was a nurse practitioner. She's like, I just wanted to make sure you weren't in pain. I said, oh, yeah, I know, but there's work we can do together. And I gave her my card and we started to talk about Esport and we started to talk about the things. But, there's a whole field out there, and it's going to be every part of the spectrum on where they are. So the more that we can do, and we're working, Melissa's team, the real Melissa over there, but we're working with getting training on Esport and this screening, brief intervention, and referral to treatment. But pairing that with presentations on CRS services, because part of what we're learning from some of the medical practitioners is there's a resistance when they don't know what the next two sentences would be. So if they're doing an Esport and the answer is problem use, but not an assessment that would lead to inpatient, what do I say? What do I say for that level? So giving them a set of tools so that they can foster the conversation, because if they don't feel confident that they know what they'll say, they might not engage in that conversation. So there's still so much work that we see as opportunity for us to meet those providers where they are and help them advance.
And I love how you brought that up, what are the next two sentences? So, and it's not just what happens when there's problematic use, but you don't have an immediate need service to send people to, but what happens when people talk about problematic, chaotic use, but won't say yes, and don't take that referral to treatment. What else can we say? And how can we say it in the most destigmatizing, non-judgmental, warm way that keeps people coming back and lets people know that you care? And one of the easy ways, besides learning some of that harm reduction language in counseling and being warm and caring and non-stigmatizing, is offering naloxone through prescription, if a provider, through handing it out, or through a bridge with another program, because nothing is, there's no easier way to say, I want to keep you alive, than offering that right there. And not making it just about treatment if someone has said no to you. I also, again, to the earlier question about what else is in that spectrum of harm reduction that we can be advocating for when there's controversy around certain elements of harm reduction. And we have another breakout on low barrier MAT or MOUD. That's another one. We as agencies and advocates and as government entities have put out a ton of naloxone over the last few years, thank goodness. We can also advocate for money and resources and work to be done on MAT in the lowest barrier way. So as an example, we've gotten to a place where we went from it costs $80 to $125 and you need a prescription for naloxone to the lowest barrier ways to get it possible. And we obviously, for a lot of regulatory reasons, can't do that with buprenorphine and methadone, but can we make at least buprenorphine prescribing and access as easy as possible? And can we try to get there around methadone? And right now, short of policy changes on the buprenorphine end, for any of us that are in healthcare institutions or substance use treatment, or that are advocates in the community, what can we do to change how long it takes to get an induction, what that looks like, and how easy it is to get medication. We get, for example, providers ask us, well, how do you give people buprenorphine that don't have insurance? Well, we are, thank you to the health department, Zoe, we have a grant of $25,000 to be able to provide buprenorphine to people who don't have insurance. We go over that every year, but that's an example of something that we can advocate for, is using, not necessarily the money that's going into naloxone, that might be one way, but finding some other creative pots of money to pay for buprenorphine for the uninsured, because that really is a big barrier. And sometimes when someone walks out of that clinic without the prescription in hand because of not being insured or because their prior auth didn't go through, that's a chance to lose people and not have them come back and have them be at high risk. So that's another thing that we can do. And many of the substance use treatment programs that offer methadone are extremely low barrier. You don't need an appointment. You don't need an ASAM level assessment. You can just go in and you can do an intake. And then at some point in the next, 24 to 72 hours, theoretically, you can get medication. But those are things that we can also fight for, is, in the same way that we've worked over the last 4 or 5 years to get naloxone in people's hands right this minute for free. What can we do to the day that you say, I want substance use treatment, I'm done? How can we get medication to people as quickly to that moment as possible?
We have 2 raised hands. Let's ask Vince to go, and then Lynn right after Vince.
Yeah, real quickly. I was going to say something about the prescribing practices earlier. It's an interesting thing, but just to talk about the MAT. I mean, one of the things that has been going on, like in Chester County, and there's more funds across the state right now for opioid and opioid related services than I think there's ever been. It's an really interesting concept. 7 or 8 years ago, I didn't have enough funds to make sure I could put people in treatment, and that was any treatment. Now I've got so many funds that we're trying to figure out how to use them so we don't lose them. And what we've been able to do is really, and it's an educational process, philosophy, that type of thing, but reaching out to our contracted providers who historically that hasn't been their practice to do, or to even have MAT available, and to use some of the funds so that make them available so that individuals that do come in can, possibly get the Vivitrol, working on the buprenorphine and the Sublocade type of thing. Some of it's, so in our system, for example, some of it's an educational type of thing, and then also supporting them with the resources they need to be able to do it. I don't know how many people on here know, but I mean, a lot of the providers, they aren't, nobody's getting rich off of this, especially if you're in a public system. And the providers don't have the resources necessarily to hire the doc or the nurse and have the room and the, for the injections or whatever. And fortunately, not as much as we'd like, but we've been able to move and provide some of that type of equipment and support so that they can do that. And that makes it a whole lot easier, and I think the other piece is we're working with them to make sure that anybody that's got an opiate use disorder, that they're having the conversation, at least that there is MAT, and it's not just mention it at the first assessment or whatever, it's bringing it up in the 3rd session or whatever, to make sure that they remind the person that there's opportunities. It's not saying that they have to do it or don't have to do it, but so there's just a couple of things we've been working on in the county here. I think it's probably more of a statewide type of thing, especially from the SCA side, where that's more and more of an occurrence.
And thanks for bringing that up too, because I think those are creative ways too, where you might have a provider that's already doing substance use treatment, but what they need to get to scale is another medical provider or a social worker or a recovery specialist. And so or a trainer, a dedicated trainer on site who maybe has the recovery specialist background, whose job is to change hearts and minds in the agency around what you prescribe, what you offer. And you also brought up the Sublocade. Another wonderful thing that happened to us 2 years in a row, after the Sublocade was approved, we got a grant from Community Behavioral Health at our SCA to provide a certain number of Sublocade injections for free prior to insurance being either in place or authorizing. So it's been our experience. I don't know if other people in this breakout are in an agency where you're doing MAT, but the sublocade, much like buprenorphine, has not been an easy prior authorization. We've had to go back to the insurance companies sometimes 3, 4, 5 times to try to get the sublocade. We've had to prove that someone has not been stable on the buprenorphine for a while. We're getting the first year, then try Vivitrol. Well, Vivitrol is contraindicated for someone who needs sublocade because they have not been doing well on buprenorphine and are still not opioid free. But at any rate, at $1,580, an injection that can save someone's life for 30 days and it's not for everyone, but for some people who do not want to go daily to methadone or weekly or monthly to buprenorphine, or who are otherwise stable and want to have that coverage for the 30 days. And we know now that, that coverage will last longer after being on the medication for a while. $1,580 is a huge barrier if you're either uninsured or that prior auth hasn't come through. And this is another way to use funds and to, it is harm reduction as well.
Lynn.
Well, I'm going to follow up on what you said about insurance as being difficult. We were talking about getting assistance for uninsured, but we do have to remember underinsured, because I know personally of someone who had a prescription for Suboxone, wanted to do that, had insurance. However, the copayment for it and the reinsurance required that he attend counseling once a week for the entire time that he was going to be on that prescription. And that's another barrier when you don't want to tell your employer that you have to leave early every other Thursday because your insurance isn't going to pay for your prescription unless you also attend counseling sessions. So it's not always just the uninsured who have an issue. It can be insured. And like you're saying, getting those approvals can be difficult.
Dr. Cassidy mentioned in her opening slides about the ROPC that one of the many things we've done over the last several years has been to have a series of dinner meetings with medical directors from, I guess, 5 or 6 different carriers, public as well as private insurance. I would assure you that this is a priority for us to continue. And along those lines, as you speak about prior authorizations specifically, that's a huge priority for many of us. Certainly for the folks at the Medical Society, it's one of the biggest reforms that we are looking for from the General Assembly. But as we get closer to doing this again and can actually bring folks together for meetings, I think love to get your input. So it's another good reason for us to want to stay in touch with you. Let's hear now, though, if there are other concerns that insurance poses as barriers, and we can kind of keep that in mind and take it with us to these next meetings. One of the ones that I hear often is my son or daughter went through so many weeks of recovery, came out, did well for a little while, but now needs to go back. And I'm having problems with my insurance company covering that. And I understand that that's still a pretty big issue for a lot of folks. But I wonder whatever else is out there too. Vince, did you still have your hand up, or is that a new hand?
It's a new hand. I don't want to.
You're doing good.
Do it. It's an interesting thing, Dave, and this has been going on for years, long before the opiate problem. But I think there's been some progress. But insurances in particular. To be honest with you, I have private insurance, if I had to go to treatment, I'd almost rather go through my own SCA, through my department, because I know from what we do, I can't speak for everybody, but there's going to be the appropriate level of care. There's going to be a long enough level of care. There's going to be somebody following me to make sure that I make the connections, you know. As you were saying, you know, I've had calls from parents where first you have a girl that needs inpatient treatment. There's no doubt about it, but they have to go to outpatient and fail first type of thing. I hope that's gotten better, but I also had the call later on where she'd been in for 5 days and it was an opiate. So 5 days in residential and they were ready to move her to outpatient. Well, she hadn't detoxed, let alone do anything else in like a rehab level of stay, which is really where they needed this to be. Now, I think as I work with some different insurances and stuff, I think there has been progress. You know, I really do, and I'm glad to see it. But boy, when you have to fight for the benefit that you supposedly have, and when you don't know how, you know, what the resources are. I mean, I could do it. I could call my insurance company and say, this is what I need to do. This is what I can expect. This, you know, this is what I'm looking for. Take somebody that's in a crisis and then have them call their insurance company. And the first person they're going to talk to is somebody that's looking at a screen like we are. And they're just reading benefits. They're really not able to make decisions. And even when I've called to advocate for a family, I just, you know, you have to go like, okay, you know, I really appreciate what you're doing, but I need to talk to your supervisor. We need to bump this up a level, you know, and then we might have to bump up another one before we're even done. But if you try to coach a family through that, when they're in the middle of a crisis, it's just, you know, it's a shame that it happens. And I'm sure it's not just with addiction, but, you know, that's where I'm at with it. So I think, you know, I think there's a lot of people that are advocates. I think the insurance companies are getting a little better. If you listen to them on TV, they're really good. I think it's a mixed bag, you know. I think we got a lot of work to do there, a lot of advocacy with insurance companies and legislation around that and that kind of thing. So that's just my 2 cents real quick.
And a lot of that relates to what was discussed earlier around stigma. And, you know, there's no other illness that you would have to fight for another course of treatment for in the same way. It would be completely unethical, as it is with this, for diabetes or cancer or some other life-threatening condition to be, you know, metered out and portioned out a few times a year if you've been in the service long enough. So that's something else that we can do. And I think, you know, another related harm reduction idea is this kind of, you know, friendly faces that's being piloted in a few parts of the country, including the SCA in Philly. This concept that you're not a frequent flyer, you're a friendly face. Let us redefine how we are looking at people. You know, this idea of the North Star. If you look at someone as a bad patient, a frequent flyer, we close the door. If you look at someone as someone who is at the highest vulnerability and risk for overdose, for example, then we change how we approach someone. And we do the opposite of what has traditionally been the model. Someone who uses up their treatment attempts over and over throughout the year gets restricted, when we really need to do the opposite. We need to keep layering more and more times till the time works. What are some of the other supports people might be looking for or need beyond, you know, to David's point, after this conference? How can we at the next conference or in between provide any support around helping you make your business case or debunking some of the myths around harm reduction with some of your opposition?
So, Lana, one of the things I constantly look at on this topic are, what are our other important audiences?
Mhm.
we have a tendency to throw all the wagons together in a circle and talk inward sometimes,
Mhm.
when in fact we really need to do a better job. And it's one of the things the ROPC I think has done well also, was this interprofessional relations, where we're
Mhm.
bringing folks from academia and education together with medicine and nursing and behavioral health and so much other. But I believe, or it's my own opinion anyway, that we need to collectively adopt harm reduction as a talking point and an effort to reach more groups. I'd love to be able to coordinate continuing medical education programs specifically on risk reduction, just to keep people talking. It's another effort to attack stigma too.
Mhm.
I don't know how other people feel about that, but it's one of the real neat things about our group. We do have a very diverse group of folks that are working together quite well.
I really like that. And the interprofessional collaboration is critical. And, especially with substance use treatment, that treatment and harm reduction can coincide. They can even exist in the same service and visit, where, especially now, we see in substance use treatment, that it is rare to have someone in care who was only using one substance before getting to care, or who is completely sober of all substances while being in care. And so we are, seeing the substance use treatment world really have to be quick on its feet to figure out how to keep people in care that would have been discharged in the past because of other substances, right? We have to just look at the service from that harm reduction standpoint. So the interprofessional collaboration of how can we use recovery specialists and some of all of us and others to really teach and support each other and court all of our support and all of our opposition with creative arguments and talking points for each. I'll also just say that this paying for harm reduction, just to piggyback on Secretary Smith's comment earlier, we know that, and Tracy Pugh, sadly, there are about 5 or 6 major foundations that support specific harm reduction initiatives. And so how we pay for anything harm reduction related, from the most progressive to not, is through a multi-layered public-private partnership. So I'll just also put a pitch in that if any of you would like any help in trying to identify funds, the few private foundations that fund harm reduction, we can certainly share that with you. And we don't mind sharing any of our prior applications to them in the past. If people are interested in figuring out how to creatively use any of your public funding to also, pay for either some element of harm reduction or layering in a service into harm reduction, because that's often how we have to creatively hodgepodge extra staff to provide harm reduction services. We at ROPC and Prevention Point are certainly willing to do that. Thank you to the note takers. Thank you to Zoe for providing the tech. Thank you all for attending, and thank you for doing the work that you do under really difficult circumstances during a pandemic. Marie and others, thank you for doing what you do after huge loss and tragedy, and continuing, despite how traumatic it is, to try to send that message out and convert more people to doing what it takes to reduce overdose.